So the financial barrier is not there for victims of road traffic accidents. There's a formal EMS transport that's there, but it's usually very crowded, so it takes longer. But if the patient wants to access that free service of road traffic accidents, so they have to wait for that. And these EMS services and ambulances, they all have like Philadelphia cords and back cords for transport, so it's really a system that's working, but it's really crowded and has too much lags. So, and the system has so many barriers to implement the time is a spine principle, but we're actually finding ways to work around it. I'm going to talk about first when the patient gets to ER. When the patient gets to ER, the ERs are really crowded, and usually only general practitioners are available in the ER. I'm talking about the smaller cities, which reflects how we have problems in doing surgery in the 24-hour limit. So all the patient notes are handwritten. There's no specific protocol to assess the patients. Usually the GP says, okay, the limb is weak, the limb has limited sensations, and after a while, the patient has waited in the ER, they just call a neurosurgeon on call maybe. So the thing is, in our small cities, we also have neurosurgeons, but they're usually on call, and it's because there's a mandate from government that early career neurosurgeons have to work for several years in the resource community cities. And this is mostly due to these high road traffic accidents that we have in Iran. So in the ER, the patient doesn't really get much of good assessment neurologically and from the spinal cord point of view. So what some people do in their practice is that they have created very simplified ACM permanent score that they can use, but it's not mandatory. So there's a big gap on taking notes and checking patients. The other problem that we face is usually in smaller cities, there's CT scans available, but MRIs are usually 1 to 3 hours away. And that's a big problem, mostly for traumas other than thoracolumbar, like cervical traumas. And so sometimes we actually decide on doing operation or decompression only just based on CT scans. But this is usually not possible for cervical traumas and cervical spinal cord injuries. So having CT is good, but sometimes, actually all the time in spinal cord injury, you better have MRI, but the way we work around it is usually for thoracolumbar traumas, we only rely on CT scans, and that's a major flaw that we have in our practice. The thing is, I think AI is good at pattern recognition, so in future maybe we can develop some AI tools that help us decide only just on CT scan. So one other big burden in our practice is that when you have a complex spinal cord injury, you have to transfer the patient to a higher center. So there's like a big headache if you want to do that, because you have to call the receiving center, and the receiving center is usually a junior resident talking to, and those tertiary hospitals are really crowded, and this takes like 1 day or 2 days to actually accomplish that. So that's why when we adopted AO spine guideline to our country's practice, we actually advocate for doing surgeries for thoracolumbar fractures and spinal cord injuries in the receiving center if that's possible. And as I said, when the trauma gets higher in the spine, it gets more delayed. For thoracolumbar fractures, usually we have normal pedicle screws available, and we can sometimes, if we don't have them, some people advocate for doing just decompression without fusion and then transfer the patient where the instruments available, but this is not usually the case for cervical and more complex traumas. And sometimes we go for immediate decompression without fusions. And this is because we have a great amount of evidence for doing decompression in the first 24 hours. The other thing that is a problem in our practice is, I heard someone from Canada that said, even if you want to put patients on vasopressor for 7 days in Canada, this is a huge problem. So in our practice, it's a very big problem too. But still, I think we have managed it somehow by training the staff in normal wards because we don't have neuro ICUs in our smaller centers. The big gap in our practice is the rehabilitation. The rehabilitation both in hospital and after the patient is discharged. We don't have actually rehabilitation in the hospital because the services are free, this service is not provided. And so one thing that so many surgeons over there do, they have prepared like sheets to educate the patient's family, maybe start by doing some moving the limbs and stuff, but this is only just that and no like electric stimulation or stuff. After discharge, many patients don't go to rehab because we don't have a normal rehab protocol for spinal cord injury patients, and this part of their care is not free because till the hospital part, it was covered by the government. And what we do is we use telemedicine to actually help the patient do it, but usually they don't follow the protocols. I think maybe in AR Spine we can manage to have like some standardized protocols for home rehab. That would be a great help to it. So this was my practice in spinal cord injury in a resource-limited setting, but as I said, there are some barriers, but still some parts of it could. We usually do thoracolumbar traumas in the 24-hour benchmark, but the other complex traumas is actually delayed a lot. Thank you.